Imagine you are an ER nurse working the night shift.
Always a stressful environment to begin with.
Right. Absolutely. And this 20-year-old patient comes in. She has this debilitating chronic stomach pain. I mean, she's losing weight. She hasn't slept properly in weeks.
Which immediately sets off all your clinical alarm bells.
Right. So you do what you're trained to do. You run the blood panels, you order the x-rays, the CT scans, you check for like ulcers, parasites, infections.
You're doing the standard gastrointestinal workup.
Exactly. And the results come back perfectly normal. Everything looks totally pristine on paper.
Wow. But the patient is still in severe pain.
Yeah, she is literally sitting in front of you, wasting away in agony. So what do you do when the root cause of that physical pain isn't biological at all, but entirely cultural?
That is honestly one of the most profound diagnostic challenges we face in clinical practice today.
It really is. Welcome to a new deep dive, everyone.
We train healthcare professionals to look for pathogens, right? Or fractures. But to effectively treat a patient in these scenarios, you have to look for the invisible cultural baggage they carry into that exam room.
Yeah, you're dealing with these really muddy diagnostic waters. Because a patient's deeply held cultural beliefs are manifesting as severe physical symptoms. So our mission today is to explore this incredible intersection of cultural values and mental health treatment.
It's a massive topic.
It really is. We are going to guide you through the clinical nuances of caring for Chinese and Filipino immigrant populations. We're going to see how ancient cultural philosophies completely transform the way, psychological distress is expressed.
And ultimately, how it has to be treated if we want to actually heal the patient.
Exactly. Okay, let's unpack this.
Yeah.
Before we can even talk about the physical symptoms, we need to understand the intense pressures these patients are living under.
Right. When we look at Chinese immigrants primarily from mainland China, Hong Kong, and Taiwan, we are observing a demographic dealing heavily with what we call acculturative stress.
And just to clarify, this isn't just like being homesick.
No, not at all. It is the profound friction of living between two entirely different worldviews. I mean, you have traditional parents trying desperately to maintain their heritage.
Right.
And then you have westernized children trying to survive and fit into a societal norm that contradicts basically everything they're taught at home.
Sounds like a total pressure cooker.
It is. It creates this highly volatile environment for severe intergenerational conflict.
And that conflict pushes against some massive ancient pillars, doesn't it? And we're talking about core values grounded in thousands of years of Confucianism.
Yes, very deep roots.
Specifically, I'm looking at the concepts of Shao, which is filial piety or, honoring the family, and He, which is harmony.
Harmony is crucial. Maintaining, he means avoiding overt conflict at literally all costs.
So you just don't express strong negative emotions.
Exactly.
Okay.
Because doing so disrupts the entire family unit. The collective is prioritized over the individual, always.
Right, which makes sense in that framework.
Mm-hmm.
But hanging over all of those values is this overarching concept of mianzi, or face.
Yeah, face. It dictates reputation, social standing, and moral integrity.
And within this cultural framework, mental illness is rarely viewed as just some biological glitch, right? Or a chemical imbalance.
What's fascinating here is that it is often perceived as a moral weakness. In some more traditional subsets, it is actually considered bad blood.
Bad blood? Wow. So if mental illness is categorized like that, a psychiatric diagnosis doesn't just affect the patient.
No, it causes a catastrophic loss of face for their entire lineage. It brings deep-seated shame to the parents, the grandparents, the extended family back home.
I always try to visualize this to make it click for myself. Think of mianzi like a shared family credit score.
Oh, that's a really good analogy.
Yeah, like in Western culture, if you default on your own personal credit card, your credit score tanks.
Mm-hmm.
But, your brother's score is totally fine. He can still go get a mortgage.
Right, his financial life goes on.
But under the rules of mianzi, it's a joint account. If one person admits to a mental health struggle, the entire family's social credit gets wiped out in the community.
And nobody wants to be the one who bankrupts the family. That shared credit score translates into an incredibly high clinical risk.
Because the stakes are just so high.
Exactly. Because failing the family equals total family shame. Admitting to mental distress becomes an absolute impossibility for many individuals.
Which leads to some really tragic outcomes.
It does. Tragically, suicide becomes a statistically significant risk in these populations. It is sometimes viewed not as an act of despair, but as an escape from an unbearable loss of face.
Or a way to just avoid being a profound disappointment.
Yeah. And we see a distinct bimodal age pattern in this risk. On one end, there's a high risk among youth and students facing extreme academic pressure, where success is the only acceptable outcome.
And on the other end?
We see a spike among the elderly. They often deal with severe social isolation, language barriers, and this overwhelming, culturally unacceptable feeling that they have become a burden.
So if admitting you are depressed or anxious bankrupts the family's social credit, but you are carrying all this internal agony, where does all that pain go?
It goes directly into the body. Clinically, this is called somatization.
Somatization.
Right. It is the subconscious redirection of psychological distress into physical symptoms. The patient avoids the culturally devastating crazy label by experiencing the pain physically.
And to be clear, this isn't just a metaphor, right?
Not at all. When an individual suppresses extreme emotional distress to maintain harmony, their sympathetic nervous system goes into overdrive.
The fight or flight response?
Exactly. Chronic stress spikes cortisol levels. That chronic cortisol bath inflames the vagus nerve, which connects the brain directly to the digestive tract.
Oh, wow. So the gut-brain axis is literally disrupted.
Yes. Digestion physically halts and the stomach lining becomes inflamed.
Let's look at how this plays out in the real world with this specific clinical case from our sources. We have a patient named Wei.
Okay, let's talk about Wei.
Wei is a 20-year-old female college student. She's a first-generation immigrant, and she carries the heavy mantle of the golden child.
That is a lot of pressure right there.
Huge pressure.
Yeah.
So she presents to the clinic with severe insomnia, significant weight loss, and chronic, debilitating stomach pain.
On paper, a triage nurse might look at Wei and immediately initiate a gastrointestinal workup.
Just like our ER nurse that started the deep dive.
Exactly. But the hidden truth is that Wei is failing a critical chemistry course. In her mind, she isn't just getting a bad grade, she is literally destroying her parents' sacrifices.
We can trace this cascade perfectly, It begins with the academic failure. That failure threatens a massive loss of face for her family.
Which turns into internalized, agonizing guilt.
Right, but because she cannot express that guilt without disrupting he or harmony, her brain reroutes the distress. It manifests as somatic pain. Her stomach is in absolute agony.
And left untreated, that pain is a stepping stone towards suicidal ideation.
But I want to push back on this for a second. If I'm a nurse and a patient is sitting there holding her stomach, how do I know she doesn't just have a severe ulcer? I mean, is somatization basically a patient inadvertently faking a physical illness because they are sad?
We have to firmly correct that assumption because it's a trap so many clinicians fall into. Somatization is never faking.
Okay, so the pain is real.
Very real. Wei is not pretending to be in pain to get attention. The neurobiology of severe stress creates genuine physiological damage. Her stomach truly, measurably hurts.
So how does a doctor catch this?
Clinicians are taught the concept of the somatic gate. When a patient presents with vague, chronic physical symptoms like headaches, severe fatigue, gastrointestinal distress that have no clear medical origin after the initial exams, the practitioner must open the somatic gate.
Meaning they shift gears entirely.
Right. That means shifting the investigation toward mental health and screening for depression. We use standard tools like the PHQ-9 questionnaire.
But wait, won't patients like Wei just deny it?
Yes, practitioners must know that patients like Wei will likely underreport their emotional symptoms due to the exact stigma we just discussed.
Think about how many times you, or someone you know, has gone to the doctor for chronic migraines or back pain, and they just treat the symptom with a pill and send you home.
It happens every day.
What we're talking about here is a total rewiring of how we view diagnosis. We found the real ailment. We know Wei's stomach hurts because her mind is breaking under the weight of academic pressure.
But here's the catch. If the doctor just walks into the room and says, Wei, you don't have a stomach issue, you have major depressive disorder.
We trigger the exact cultural shame that caused the stomachache in the first place.
Precisely. You would induce an immediate loss of face. She would likely shut down, and you would lose the patient to follow-up care entirely.
So what does this all mean for the treatment plan?
This is where clinical negotiation begins. It requires a patient-centered approach, rooted entirely in cultural humility.
Meaning you don't just dictate Western medicine to them.
Right. Instead of dictating a Western psychiatric diagnosis, the clinician asks questions like, what do you call your problem? Or what do you think caused this imbalance?
You completely drop the mental health jargon. You don't use words like psychiatric or depressive episode.
Exactly. Instead, you reframe the intervention. You talk about restoring balance.
which ties seamlessly into traditional Chinese health beliefs,
Yeah.
right? Viewing health as a delicate balance of yin and yang.
And the proper flow of qi or vital energy.
I assume medication management requires this exact same reframing.
Oh, absolutely. If you prescribe an SSRI like sertraline or citalopram, you must thoroughly educate the patient on the side effects through their cultural lens.
Because side effects could be disastrous for their sense of harmony.
Right. If a medication causes weight fluctuations or sexual dysfunction, it will make a patient who is already feeling out of control feel completely toxic and off balance.
There's a really prevalent cultural fear within these communities that Western medicine is too strong or too harsh, isn't there?
Yes. Without proper framing, patients will take half doses or they will stop taking the medication the minute their stomach feels slightly better.
The flexibility required from the practitioner here is amazing. Like, a skilled nurse will actually encourage combined therapies.
Yes, integration is key.
If Wei wants to use traditional Chinese medicine, acupuncture, cupping, or Tai Chi, alongside her pharmacological treatment, the clinician respects and actively supports that.
It massively improves compliance. You are basically saying, yes, let's use the acupuncture to restore your energy flow, and let's use this medication to help your stomach heal and your sleep regulate.
It's brilliant.
The true brilliance of this reframing is how it shifts the narrative for the entire family. The clinician is no longer saying Wei is mentally ill.
Right, because that brings shame.
Exactly. The clinical narrative becomes Wei's body is reacting to extreme physical stress and she needs support to recover her strength.
That subtle but profound shift allows the family to rally around her.
Yes. They can provide warm liquids, medicinal soups, and emotional support without anyone losing face.
The clinician basically reframes the treatment, so Wei sees seeking help not as a moral failure, but as a necessary step to preserve her ability to help her family.
Her physical and mental health becomes intrinsically linked back to her core value of filial responsibility.
Okay, so this strategy of clinical negotiation isn't just a workaround for Confucian values. If you travel 1,000 miles south to the Philippines, you face a completely different cultural blueprint.
Very different, yes.
But you encounter the exact same requirement to treat the cultural baggage before you can treat the patient.
Filipino culture brings its own deeply ingrained, highly complex values to the exam room. At the very core is kapwa, which roughly translates to shared identity.
Kapwa.
Right. In Filipino psychology, the self is not an isolated entity. It is inextricably interconnected with others. You do not exist independently of your family and community.
It's like you don't edit your skin. You are literally part of a larger organism.
That's a great way to put it. And alongside kapwa, you have the concept of hiya, which is a profound sense of social propriety or shame, the fear of losing face in the eyes of the community.
So it's similar to Mianzi in some ways.
There are parallels, yes. And there is also amor proprio, which is a high sensitivity to personal affronts. It functions as a defense mechanism to protect one's self-esteem and dignity.
So if we look at how mental illness is stigmatized in this demographic, it's not exactly the bad blood concept of Chinese culture, but the collateral damage is the same.
Yes, the stigma is immense. Mental distress might be attributed to bad air, angering ancestral spirits, or simply having a weak soul.
And just like Mianzi, having a psychiatric issue brings Hia deep shame upon the entire extended family.
This creates catastrophic barriers to psychiatric care. Take schizophrenia, for instance. It is vastly underdiagnosed in Asian American populations, including Filipinos.
Why is that?
This is partly due to the dangerous model minority myth, the false pervasive assumption that these demographic groups simply don't struggle with severe mental illness. But it is equally due to the fact that the family will actively hide the symptoms to prevent Hia from destroying their social standing.
Let's create a scenario to understand how this actually manifests in a clinic. Imagine a 19-year-old Filipino college student named Mateo.
Okay, Mateo.
He's experiencing early onset schizophrenia. But the presentation of the illness itself is heavily altered by his culture.
How so?
Well, because Filipino culture has such deep Roman Catholic roots spanning centuries, when a patient like Mateo experiences hallucinations, they don't necessarily manifest as the clinical paranoia Western textbooks describe.
Ah, right. His hallucinations might manifest as intense religious delusions or absolute convictions of demonic possession.
Exactly. And we see somatization in Mateo's case as well, but the physical vocabulary changes entirely from Wei's case.
Right. Mateo might not complain of gastrointestinal pain, When describing his immense psychological distress, a Filipino patient will often describe it physically as a severe heaviness in the head or literal heart pain.
Here's where it gets really interesting, though. How do you even conduct an assessment? I ask because our sources talk about this whole concept of their indirect communication style, something called pahiwatig.
Yes, pahiwatig. It's crucial.
It's the use of highly ambiguous expressions or even just body language to maintain harmony and avoid direct confrontation.
Exactly.
So, if Mateo and his family are using ambiguous expressions just to be polite and avoid conflict with the doctor, how do you conduct a rigorous psychiatric assessment?
If we connect this to the bigger picture, this is where we see a direct, high-speed collision between Western medicine and Filipino culture.
Because Western medicine wants just the facts.
Western medicine demands direct, blunt, objective data. We ask, on a scale of 1 to 10, how is your pain? Or, are you hearing voices that aren't there?
But that bluntness directly violates the Filipino value of maintaining social decency and avoiding haya.
Yes, a culturally competent nurse has to stop relying solely on the clipboard. They have to rely heavily on nonverbal cues, tone of voice, and what the patient is not saying.
You have to read the room, the body language, the glances between family members, not just the medical chart.
Furthermore, practitioners must conduct a detailed migration history. You cannot assess Mateo without understanding the trauma of acculturation.
Right, the context of his family leaving their homeland.
Their socioeconomic struggles upon arriving. You can't just run down a checklist of DSMV symptoms. You have to understand the context of his shared identity, his kapwa.
Both of these case studies, Way with her stomach pain and Mateo with his heaviness in the head, point to one ultimate unifying clinical truth.
And what's that?
In these cultures, you are never, ever just treating the individual. You are treating the family as the patient.
That is the cornerstone of effective care here. You must honor the family hierarchy. Let's look at the logistics of discharge planning when a patient is ready to leave the hospital.
Okay, let's say Wei is getting discharged.
For a Chinese patient like Wei, the plan is not finalized just by handing the patient a discharge summary. The clinician must identify and include the eldest male or the recognized decision-maker of the family in the consultation.
You ensure you have professionally translated instructions, and you provide culturally relevant safety planning.
Like crisis lines that specifically offer Mandarin or Cantonese services, because calling an English-speaking Western hotline might feel like an impossible barrier.
And for a Filipino patient like Mateo, you address the matriarch or patriarch first. The health decisions aren't made by Mateo sitting alone in his room.
Right, they are fiercely debated and decided upon by the extended family collective.
When discussing Mateo's schizophrenia with his family, the clinician reframes the illness. Instead of using highly stigmatized clinical terms that trigger haya, they might describe the condition as an imbalance of the mind.
Or use the culturally understood concept of overthinking. The term is masyang pag-usap. This drastically reduces the stigma.
And to encourage adherence to antipsychotic medication, the clinician frames taking the pill not as treating a defect.
Right, but as a necessary tool for Mateo to fulfill his obligations and role within the family, thereby restoring his honor and their collective standing.
This totally flips Western individualistic medicine on its head. I mean, in the West, healthcare is entirely about autonomy, high PA regulations, the individual's absolute right to choose.
The individual is the center of the universe.
Right. But here, you literally have to win over the grandmother or the eldest uncle before you can realistically hand the patient a pill.
Because if the matriarch doesn't buy into the treatment plan fails the moment they leave the hospital parking lot. This raises an important question about our own practices. Clinical success ultimately depends entirely on a practitioner's ability to navigate the delicate, often unspoken space between Western pharmacology and deeply rooted Eastern values of harmony, face, and balance.
It's not just about knowing which specific medication to prescribe.
It is about knowing exactly how to present that medication so it is culturally acceptable and practically viable for the patient's entire social ecosystem.
It is the ultimate form of clinical diplomacy.
Truly.
To wrap this deep dive up, what we've learned today is that to care for a Chinese or Filipino patient is to care for their entire lineage.
For a whole family.
Whether you are dealing with Mianzi and stomach pain like Wei, or Haya and religious delusions like Mateo, the master key is cultural humility.
It's about dropping the clinical jargon, opening the somatic gate to see the psychological pain hiding behind the physical symptoms, and reframing care as restoring balance.
You treat the invisible baggage first, and suddenly the physical pain begins to heal.
As we close, I want to leave you with a lingering thought to ponder on your own. We've spent this time exploring how Eastern cultures somaticize psychological stress into stomach aches or heaviness in the head because their culture relentlessly demands harmony and family success. But I encourage you to look inward at our own environment. What culturally acceptable physical symptoms might you be manifesting right now? Perhaps chronic insomnia, tension headaches, or digestive issues, simply because Western society demands relentless productivity, constant hustle, and fierce individualism.
Wow. Think about that the next time you get a stress headache and that x-ray machine comes up completely empty. Until next time, keep digging deep.